What's that word? What's that word? Indignant? Indigenous? What?
Well, it's funny you say
Indigent.
that because we do
Indigent.
a lot of these that are closed
Indignant.
without video, and I've had panelists come up and say, this section right here, did I say this? And I'm like, well, yeah, we just cleaned it up a little, and they've asked to see both of them. Wow, you made me sound really smart, and it's like, well, we're just polishing things, which is great, but
I need all the
course-
polishing I can get.
the issue, of course, is we can do all we want with print, but
Well, what's
video
happening with the
segments-
video bits? Tell us
In
that.
all likelihood, what we'll do is maybe pick out some segments that just kind of naturally came together well, and they would be embedded into the digital supplement. So what happens is once the print supplement's created and it's approved by everyone and it goes to print, our media team converts it to a digital supplement, so it's like an online version exactly that has split pages. So within that, they can embed video. And really that'll be up to Jason and his team to decide if
they
and
want
how
it,
they want
okay.
to use that. And then before they do, they'd of course have to come back to all of you for approval. But my guess, based on previous experience, is that it would just be,
Like a
snippets of
phrase
the
here and
conversation
there.
that came together nicely and that, fit in well with the print supplement.
Okay.
Should we be looking at one another? Should we be looking at the
somebody's talking, I
camera?
imagine.
Or are we talking to each other?
We're
Are
talking
we-
to each other.
You're
talking to each other?
I
Yeah.
think that definitely works better.
Are we
for
supposed to
the
face
center.
each other as we talk? Or
No, I mean-
can I just drift off into this
Yeah,
romantic?
That's why I wanted to be.
Kathy, yeah, so Kathy, if you don't like art, you can just push him off the edge of the
I'm
view.
gonna-
Those fall out of the end of the view.
Hey, that works both ways.
That's true.
How could you say that?
So wait a minute, is this boy, girl, boy, girl?
It is.
Oh, that's I know. See,
That's all right.
You were just looking out
See?
for you, Kathy. You were
Thank
just looking
you.
out
Yes,
for you.
look at that. Wonder my battery is
Oh, look, they're
lagging.
getting us from all angles.
So
they'll have
Jason,
this
as we
neck
go
thing.
through this,
Photoshop that out.
Absolutely gorgeous.
Thank you. I had some water in the bottle. What happened to my water in the bottle? Message in
Well, that's why I put this in a glass.
Your cosmetic
Here, I know, I need one.
Thank you.
Actually, do you all want one that you can kind of just keep next to
May I
you?
have a glass with me?
Yeah.
I'll get a
I
glass.
have one in the
Actually,
glass.
do we have any vodka? No, vodka, actually. Do we have any vodka or scotch?
Yeah, it's not vodka, it's not blood. It's water.
Good.
I was just gonna say
Oh,
that
yeah,
as
I
we
had
go
some leaf
through,
on here or
if
something.
you feel like we haven't gotten something yet, or even at the end, this gets a little tricky in the middle here because it's all like a bunch of paragraphs. So I'll say something or have some comment like we talked about the other day.
If there's one general, well, let me say it this way. If there's two real priorities that I want to accomplish, is number one, to raise the level, the whole purpose is to raise the level of awareness that the numbers in terms of prevalence, in terms of an absolute number, the frequency which it's hiding amongst routine dry eye, the importance of finding it because as it progresses, the fact that there's serious complications, it's important to find it early. And that this dynamic of not only, so we should be looking for it when we assume it, but actually, how do we find it not when it's obvious, right? So so number one, find it when it's obvious, of course, but it's not just the dry eye, dry mouth, fatigue. I mean,
Joint
the
pain.
early stage Sjogren's doesn't look really all that different than other early stage dry eye that doesn't have Sjogren's. There's not real clear. You don't walk in with a red hat saying, "Hey, I'm the one that has it."
Okay.
But I'm really excited, and I thank you guys all for taking time to be here.
Well, at the very end, if we
Yeah.
haven't hit something in particular, you kind of make some notes as we go
I
through
will,
it.
yeah,
We can come
maybe
back
that-
and do a few more sound bites on
Actually,
it.
Jason, if they're going along and they touch on something and then they are ready to move on and you want to expand more on it, you can stop because you didn't intend to use the video as a full thing, start to finish. Right, so it's going to be edited anyway, so if you want to interrupt and have them, just kind of go back and redirect if that comes up, feel free.
Awesome. That will do for sure.
So you guys
And-
use
I mean,
Final Cut or
and
all?
Jason, the one thing that wasn't
Wait.
really
Do you have a
talked
pen?
about
And
By
new
any
the
chance?
iMovie
other day
is
is
really
just how
powerful.
early it would
Do you have a pen?
detect.
No,
Well,
I
Did you have
So
a pen?
that's a great,
May I?
great question. So we're not even really talking about this test as much in here, but the fact is that the biomarkers, depending on which of the models and which of the case studies, they'll pick up 50% of the cases
Thank
that
you so
would not
much.
have been picked up
Thank
with
you.
Roma. And it's never been really quantified how early, like how many years earlier.
should have one too.
There's a number of instances where it was 4, 5, 6 years earlier. It's just hard to
This
determine
is
because
nice.
Roland may
It's
never show up.
ergonomically
Right.
And so as
Right.
compared to, it's.
I mean,
it's
I've
a-
had some very advanced patients that never
show,
get.
never shows up. But the idea is that it's definitive that SP1 in particular is one of the earlier markers of the disease.
But that hasn't been determined yet exactly
Determined
how
X
early
number
or.
of years, no. No, I would like to have that as
Because
a
that would be
claim at some point, yeah.
incredibly valuable information as a screening tool to.
Now, would you like us to put this in the context of dry eye as a general disease? Yeah, that's what I was thinking, so, okay.
Yep, so if you think of that slide where, there's 25 million patients with dry eye,
Yeah.
there's 4 million with Sjogren's, and this 3 million we're trying to find are commingled within that dry eye market.
Okay.
Well, my thinking is that there's a lot more than 25 million.
Oh, yeah,
right,
true, well,
right,
true,
exactly, yeah.
True.
My
So-
thinking is everybody has dry eye.
And if they don't, by the time I'm
Till
done.
till proven not
Hey, well, you
to.
know, in our sample of postmenopausal women over the age of 65, you know, like 70% of them have dry eye.
I believe that.
Exactly.
And of those, it's like complete mix of stuff usually. You know, so
Which they attribute to a host of other things
Yeah,
that
and
may not be able to
medications.
recognize.
No, I don't have dry eye most of the time, but sometimes I do. I look at those electronic records
That'll do it.
all night
So
long.
you want this to be somewhat clinically focused to generate interest in the piece and sort of draw people in. And you want it to be not proprietary, but more,
yeah, at the very end, there's the only little bit we'll talk about it in the last little bit of the 2 slides that Felix showed. And so we'll talk about that just a tiny bit at the end, right? 'Cause-
well, it is by nature proprietary, because you don't really have the only game in town, so.
Yeah,
You know.
what this is, from a marketing perspective, this is another tactic executing the same story as the Sjogren's and Nicox co-brand. Actually, the Sjogren's Syndrome Foundation is going to endorse this roundtable. They're going to put their logo on this work.
That's really great.
They're comfortable with it once they read it. But they were very excited to be.
She's like, I'll make sure of it.
Cool.
So this is essentially another tactic like the sunflower ads. This is really just another example of us bringing education on the disease to the market.
I wonder why they
My
picked the
biggest fear when
sunflower
we
instead of
when we walked
daisy.
away from that meeting is that a lot of our colleagues are going to, you know, as I mentioned, become arbiters of who's going to get the test and who's not going to get the test, or not be able to position it within their conceptualization of dry eye. So I think one of our jobs is to really make it comfortable for them to understand that this is an important element of the dry eye workup.
Yeah.
In my mind, I visualize, even if you think of the sunflowers, right, so you have that progression, that end stage, the patient. When people think of Sjogren's in general, they think of certain particular patient type. If that's like a 9 out of 10, right? This test is not it's not going to be successful. It's not going to really do its job if it's
it's not.
positioned to test everyone who's at an 8 out of 10. And we're now screening out who's at 8, you know, and okay, well, we're looking for some trigger to use the test that is those that we're pretty sure have the disease. But I don't know how far back is appropriate. It's also not a 1 out of 10. It's not everyone who walks through the door. But it's kind of positioned early enough in this progression that it actually is useful.
I don't know about that one.
Everyone walks in the door.
Not everyone who works in the door,
But anybody that
everyone
is a
you
dry eye
would-
patient.
dry
right?
patients.
Yeah,
If
all
they
dry
wear
eye
dry eye.
patients that walk in the
Identified
door.
But it's a piece of the puzzle which was completely absent from most of our grasp before, that now has become accessible to us.
Are we
So-
recording? Because this
No,
is
I know, I
golden.
know. Okay,
Yes,
let's
right.
get started, everyone.
That was good.
Okay, save that.
Hey, wait a
That
minute.
was great.
This
That was
crack-
good.
I know you want to
This-
practice, but let's
This
do
crack
it.
keeps- this crack
Jason,
goes
jump up
naturally.
here.
All right. When can we start? Anytime anybody, right? All right.
We're rolling whenever you're ready.
Okay. All right, well, welcome, everyone. Today we're going to be talking about Sjogren's syndrome, which is a topic that perhaps our colleagues would appreciate hearing a bit more about. It's not often talked about in the dry eye arena. But before we get started, I wanted to have each of you introduce yourself. You know me, I'm Kelly Nichols. I'm at the University of Houston, College of Optometry. I'm a professor there, and I am the director of the Ocular Surface Institute, which is a clinical research center. We also see patients in our dry eye center there. We are housed in the same facility, so patients often that participate in our patient care then sometimes join our studies and vice versa. So I have the opportunity to see patients from a Sjogren's perspective, as I know you all do too. So as you introduce yourself and say a little bit about where you're from, perhaps you could tell about a Sjogren's patient that you have seen or that has been on your heart or mind for a long time as a way of introduction. So I'll start out with you. Go ahead and let us know a little bit about yourself.
Okay,
Ed.
I'm Doug DeVries. I practice at Eye Care Associates of Nevada in Reno, and also at New Eyes facility in Las Vegas, Nevada. And 80% of my practice is really limited to treating dry eye. And as a result, I see some very advanced patients. So as soon as you mention Sjogren's patients, I have this image of several of my Sjogren's patients. Many of them have been to multiple eye care providers, even outside the regional area, seeking help and trying to find some remedies for their situation. But you tend to think of that as a more advanced. When you say Sjogren's patient, that's a more advanced patient that you're thinking of.
I'm Catherine Mastroda, and I am at an optometric referral center. And there I have the privilege and the luxury to see patients that are sent in by my optometry colleagues. And it's often for surgical care, be it cataract or glaucoma. And when the patients come in, they may have the comorbidity of dry eye or have a working diagnosis of Sjogren's. And usually I see them with those who are diagnosed in that capacity. They're coming in for cataract surgery, or they're coming in because they also have glaucoma. So some of them do have the diagnosis, but others of them have symptoms of dry eye, and we have to think about those in context of cataract surgery or glaucoma surgery or even retinal surgery, retinal injection. So when I think of the diagnosed ones, I think of those of how we have to manage the challenges of cataract surgery or any surgery with that patient. And it can be, complicated.
Thank you, Kathy.
Thank you.
My name is Art Epstein. I'm the director of the Dry Eye Center of Arizona, which is part of Phoenix Eye Care, Phoenix, Arizona. My primary focus is dry eye and ocular surface disease. In fact, I sometimes like to say that I'm immersed in the tear film because that's really most of what I think about most of my clinically focused waking hours. It's interesting, you mentioned a Sjogren's patient that's near and dear to your heart, and one of the things that's very powerful about Sjogren's patients, they're probably part of the group of patients that are in most need in our practice, and I think our hearts really go out to them. I immediately was drawn to a patient that I just saw earlier this week, who I'm worried about right now because she was in distress. Her life had been irretrievably altered, and I'm extremely excited to have a group of colleagues that I have such respect for to be able to discuss this and focus this in a way that will be more accessible for all of our colleagues. I think this is a major step forward for all of us, and I think I'll have an opportunity to discuss my patient in a little bit more detail as we go on.
Great. Well, I heard all of you say that the patients that you see in your practice that have Sjogren's that you know of tend to be in distress. I like that phrase. And I think that we all want to do something for them that will help them not be in distress. In my mind, early detection, and there's not really a way to do prevention in this case, but early detection and early management can help prevent that distress, I think. And I think we'll be focusing on that as we go through today, and I want you guys to keep that in mind. Let's talk a little bit about the condition itself. We all learned about this in school a little bit. I have a few statistics to talk to you about, which I'm sure you're aware of. They're kind of traditional statistics, but they do hit home when you hear them again. It's thought that at least 4 million people in the United States have Sjogren's, and that's kind of a large number. I mean, I think we think of Sjogren's traditionally as a small condition that people don't really have, or we might not see very often. But what do you think about like that statistic of 4 million people having it, but perhaps 3 million of them are undiagnosed? I guess I'll start with you, Kathy. Why do you think that happens, and why do you think they're undiagnosed?
I think that, because patients come in with a common complaint, we all hear them, the itching, the burning, the dryness, it all gets put into a box of, well, we all have that a little bit, which sort of holds to why I think we all have a little bit of dry eye. We all try to manage it in a palliative way, prescribing tears and trying to make them more comfortable. But we never really think of taking the next step, and trying to understand why is that that happening. We may address environmental concerns and smoking and health issues, but we sometimes skip the step of something underlying, something more core to what's going on with them. And they never really continue on to have a medical diagnosis made. And I am, culpable of that myself, thinking that I can handle it in my office with my tools and the things that I know, but never really move on to the next step, which I think is probably something we all should do more.
Well, in your setting where you're seeing patients that are being referred for cataract and glaucoma, don't you believe that the patients are coming in with those specific concerns, and it's easy to not address, the dryness bit?
Absolutely, and as a referral center, your patients come in and, they're sent in, this is my patient, we're having cataract surgery. But in the back of, the patient telling me they have blurry vision, I have the old other, and, it can be intermittent, or my eyes burn too, and the patient will associate the burning with having the cataract, and then the cataract will be done, but they're left with the burning. And, in the referral practice, often that gets sent back to the co-managing doctor, and it's out of my hands. So, that's one way that it escapes, my care in that regard.
Yeah, I'd say that 9 out of 10 patients that have that comorbidity of dry eye and cataract, when they come in their mind, they're thinking that it's
they're
the cataract
together.
that creates the variability, that they can have an alternate or an intermittent vision and intermittent clear and blurry vision because of the cataract. So yeah, you're absolutely right, Kathy.
Yeah.
They're not thinking in a direction of dryness at that point.
And frankly, they're disappointed that even though they see better, they're not feeling better.
Right.
So it's an unresolved concern.
And how about that in your practice?
Well,
Mark?
it's actually interesting, as I really resonated to that. One of the things that I found to be a truism in life is to hammer everything's a nail. And even though a significant percentage of patients who come in with dry eye, and I think a much greater percentage than we traditionally believe to have Sjogren's disease actually do have Sjogren's disease, I think what ends up happening is we see them as a dry eye patient, and as you said, we treat them in a stepwise fashion, which has been altered over the past few years, and I think much for the better, but we don't go to that next level. And to me, that's actually the most tragic part of it, because those are the patients who advance and become significantly impacted by their dry eye, and then they begin to show the other signs of classic Sjogren's. We see them first, and we often miss them because we don't recognize them as actually having Sjogren's. And I think that's because we see everyone as having dry eyes. We don't see them as having a systemic disorder.
I think about it too, relative to we just didn't touch on the glaucoma patient. That same glaucoma patient is coming in as a glaucoma patient, and in the minds, you're thinking manage that. But certainly addressing the dry eye in that particular case is really important because it impacts their ability to have a successful surgery should they need a glaucoma surgery. And I think that, if that then fails, even in that instance, we may be missing the boat in terms of a Sjogren's diagnosis when we're so much more focused on the glaucoma aspects and managing that. So awareness here.
We also give the cause of their dry eye, oh, well, it's all those glaucoma medications that they're taking and the preservatives and all the things, that we're doing with that glaucoma diagnosis, instead of maybe reminding ourselves is, you're allowed to have two things at once.
And we're really looking for symptomatic relief with our dry eye patients.
Right.
I mean, that's what we're moving to, as opposed to looking to the root cause of what's the underlying factors that are really giving this condition. And while we'll justify and we'll look at medications and we'll look at some, and how often does it, I'm sure many early Sjogren's patients just get dismissed as being perimenopausal as opposed to perhaps early Sjogren's, because we kind of justify to be able to treat those symptoms.
Well, that's a nice segue, actually. For the Sjogren's patient, 9 out of every 10 Sjogren's patients are female. So it would be quite easy to then sort of push that away. Think about the Sjogren's patients you've had in your clinic. And have they been male and female? And can you recall a male patient with Sjogren's? They exist.
They do exist, but I think I now understand that there's some male patients that are undiagnosed Sjogren's. that have never been tested by either rheumatology or by myself, but the vast majority are female.
I would agree. I would agree. The male Sjogren's patient is the rare bird. It's
Yeah.
the white albino gorilla.
You
You
know,
don't
but-
see many.
Yeah, it brings me, I can think of, as we sit and speak, 5 young men who had truly dry eyes, and I just couldn't figure out why that was. And I think, should I pull those records
Yeah.
now and take the next step? Because it's something that I just couldn't put together, with what I know and what I learn and what is what we think.
I also wonder if their presentation isn't milder than some of the females have. So it tends to be delayed in onset, and we tend to miss it more easily. There may be, as Doug said, a significant number of males who actually are impacted with it and will have significant morbidity as time goes on. And again, an opportunity to diagnose and intercede in the disease process early on would help those patients as well.
Can we call that diagnostic prejudice?
Well, I guess we could, and I think that even though that number exists, I sort of feel like, well, yes, 9 out of every 10, but what about the guy? I mean, it's just as impactful to him to get a diagnosis, and so that's where early diagnosis could be really beneficial, because what if one of them, and then I've seen, is a Sjogren's patient, I didn't recognize that.
I also think
Psychologically.
that the
No,
male
sorry.
dry eye patients also tend to be in more denial
Yeah.
and stoic about saying, no, I don't want to
Probably.
really, I don't really address this problem.
So you're
No,
saying
it's
that women are
okay."
complainers?
No, and actually, women are action takers.
There we go.
Action takers.
I think psychologically, I think it's much more difficult for males to come to grips with it. I find it much easier to deal with the female Sjogren's patients who are really more accepting of it and more willing to work at it. I think it's difficult for males to admit, that type of issue.
I had a male patient that had cancer, and so some of his cancer treatments could very likely be why he developed dry eye. But he could have, just as easily had Sjogren's, and he was a firefighter and and he said, I beat cancer and I am a firefighter, and this dry eye is going to bring me down. And I thought, wow, that's just very powerful. What if he was Sjogren's and I didn't know it?
Did he happen to have lymphoma?
I know, really.
Because I can think of several
Yeah.
patients of mine that's how I got them at that point. They were so severe, and it was actually a lymphoma, undiagnosed Sjogren's.
Wow. Well,
Undiagnosed
1 out
Sjogren's.
of every 5 patients that has Sjogren's dies of lymphoma.
Right.
And that's a powerful statistic as well.
But you raised an incredibly important point. These patients really cry for help more loudly than most because they're completely out of control. Their lives are turned upside down. They're really miserable, and that to me is the most tragic part of it. You take a hulking fireman, who's used to saving lives and going in, and suddenly he feels like he has
What
nothing he
that
can
was
do.
it. Oh, I feel horrible.
And just to follow on that, with the dry eye patients are difficult patients. And I think because of that, they sometimes get bounced from practice
Yeah.
to practice. That, she's here again, because they hear the same things and they get the same treatment, and they're still uncomfortable, so they come back again, and it begins a cycle of misery for a patient. And I think being able to make a diagnosis earlier can probably empower them to do something about what's giving them trouble.
But you said something that really resonated with me as well. And by the same token, this young lady that I mentioned before, this Sjogren's patient, had been through the rounds and had seen a number of clinicians, had seen a local cornea practice, and was very, very frustrated and came to see us. And clearly she had Sjogren's, she was diagnosed with it, but part of the problem was that she also had meibomian gland dysfunction, and she had exposure, and she had an absent Bell's phenomenon. And everyone was so fixated on the Sjogren's that they
They
missed
missed
all of
everything
the other
else.
things, which was just adding to her burden of misery. So I think the great thing about this dialogue, is that we recognize that these people are part of a complex puzzle, and we recognize the complexity more than we ever did before, which really empowers us to learn about it and integrate all of this into our practices, because we'll better be able to address their problems. So instead of going from doctor to doctor, it'd be great if the patients were able to get care, be diagnosed properly, and be managed properly pretty much everywhere.
And the hallmark that you said, our is so true. All of us have identified those patients who have bounced from practice to practice because of the frustration, because they haven't been identified. I mean, had they been identified at an earlier stage, I think the treatment and the compliance with the treatment would be completely different.
Well, and they may not get to the point where they are so severe that their quality of life is so reduced.
Yeah.
So what we're really talking about is the statistic, which I think is the most notable, remarkable statistic we'll talk about today, in that it's an average delay of 4.7 years to diagnosis for a patient with Sjogren's. And I think about that, and think about it in context of me. Here I am, a year-old woman, and I have some dryness in my eyes. Yeah, there's a little MGD. My aqueous production isn't great. Could be me, right?
Could be you.
And I might not really, even though I'm in this eye care profession.
Shoemaker's daughter?
Yeah, right. I'm in this eye care profession. I'm not trying to be a hypochondriac about having a condition, but in reality, it could as easily be me as it could be anybody that's in this room, likely, who has dryness, and we all have a little dryness from time to time. And I think about 5 years of my life trying to sort that out. That's a long time. So it's really, and I hope that, each of us will, as we go through the rest of today, think about that 4.7 years and what we could do through awareness and through working with our patients and our colleagues to reduce that. The Sjogren's Syndrome Foundation has a goal to reduce the time to diagnosis by half in the next 5 years. And I think that through programs like this and awareness, it can really help.
What a difference that would make in
Medical
treatment.
need.
What a difference that would make.
Yeah, wouldn't that be?
I think
You know, it makes me think of CDC report on the acanthamoeba outbreak, and the delay from presentation to diagnosis in some cases was 180 days, 80 days rather, with an active infection. And you think, how tragic is that? These patients suffered all this time. So here you're talking about something that is literally life-altering for these patients and fairly common, and yet these patients bounce from practice to practice, and the delay goes on for years and years and years.
Yeah.
And that's unacceptable. I mean, patient expectations are that we diagnose promptly and initiate treatment quickly and halt the disease process as best we can, as quickly as we can, and we have to do better. We have to do better.
you see patients, opposite you, and they're wondering, what's wrong with me? And now they'll have a diagnosis so that they know what's wrong with them.
Knowledge is power sometimes.
Knowledge is
yeah.
power, and
Absolutely.
speaking to different doctors, and you have dry eyes, and same redundant diagnosis, but still unresolved in their mind. It leads to depression and frustration, and that frustration is mirrored in their relationships and with your front desk people and with you, the doctor, and having a diagnosis and being able to work with their caregiver, their health providers is monumental in just their lifestyle and thinking
You're
about
exactly
them,
right.
thinking about themselves and not thinking, well, I must be
And-
crazy. I
Crazy.
must be crazy.
Well, I'm sure they've had practitioners tell them they're crazy or they're just
Just
No.
tired.
tired.
And I'm culpable of saying this. Well, your knees wear out and your hair turns gray and your eyes get dry and we'll turn off your overhead fan and move your computer screen when maybe I should be saying, let's really dig a little bit deeper.
And what's been the impact on care? How many eye care practitioners don't want to see these patients?
Right.
How many dread that?
Yeah.
And
Not
that's
just eye care practitioners, general practitioners who are hearing the fatigue complaints and
Aches and
such.
pains
Yeah,
and
aches
the-
and pains.
We like being able to fix people, and when we can't, it's frustrating.
Well, from an
Knowledge
eye
is
care,
power.
from an eye care perspective, I know that I think we've made leaps and bounds in terms of dry eye diagnosis over the last several years, and we know of all the associations, systemic associations with dry eye. I'd like to review them. Like perhaps you can think about the questions you ask in your exam, but review them in light that some of those associations might be parts of Sjogren's disease. So if in the way that you ask your questions, or maybe you can go through the way that you ask your questions to your patients about their systemic history, or what might be on your intake form, or or a survey that you might give out, that might, shed a little light on some of the things that we should be remembering to ask Do you want to start out?
Well, yeah, I definitely think there's an alteration in intake necessary, but there's also, because we go through and try to identify, specific environmental concerns and medication concerns of patients. But I think in terms of the, more probing questions as to, perhaps aches and pains and those other systemic problems that may manifest. I mean, honestly, on my patient that I'm initially taking in as a dry eye patient, I don't do that, and I perhaps should do, more of that with an intake. But I think the statistic of how many Sjogren's patients there are and how many are undiagnosed is quite alarming, and that's, to be able to find a means to get to that is what we really need, and whether it's through getting earlier symptoms is one thing, but yeah, we definitely need to be able to track that.
As we go through this, you have all your questions about your blood pressure and your cholesterol and all the things that, emphysema and what medications do you take. But, I mean, if you think about every time, you'll sit your patient down and they'll flap into the chair and they say, how are you? I'm so tired. You maybe, we don't ask on our history form, do you think that you're more tired than the amount of work that you accomplished that day? Maybe we should ask patients, are you more tired? And as a mother, you have family and children and obligations and work and school and PTA and say, yeah, I'm tired. But are you really more tired than what you should be able to do? Not to mention the patient who'll just volunteer, or maybe we should ask, are you always wearing your gloves in the winter? My hands are always cold. My feet are always cold. Maybe that's something.
What about the aches and the
aches and
mom who might actually be a runner, or whatnot, who has aches and pains, or the person who likes to do gardening and always is complaining about their knees,
or carrying all the groceries, and it just gets dismissed as well, day to day. Well, I do it too, and my knee hurts as well. But never really ask, are you tired?
I tend to be more structural in my approach, so I'm looking for associated rheumatoid conditions, which actually may well be associated with Sjogren's.
How do you ask that? Is it on an intake?
Basically, an intake.
Yeah.
Sometimes it's missed. Patients don't always put down everything, so I'll go back and ask again. We had a patient recently with thyroid disease that wasn't listed, and then they came back and said, "Oh, yes, we did." And it was
Do you find their awareness of those words is okay? I mean, such as, if you listed to a patient, do you have Sjogren's, rheumatoid arthritis, lymphoma, or, do they lupus? Did they?
That's actually a great question, and I find that the patients that have been through the system a lot are much more self-educated than they have been in the past. So they actually are much more familiar with the terms than they were, and in fact, they give you a fairly accurate indicator of their general health status, much more so than the average patient does. The other thing that I think is very important is the first thing I do is I look at the patient. I just look at how they present, and in fact, I'm working with a new tech, and I've tried to explain to the tech that I refract by sight, and she was confused, and I said, watch the patient's face. Before I even ask the question, you can actually see the response that's going to come by watching the facial expression. We just put a bandage lens on a severe dry eye patient the other day, and I said, looked at the patient's face, and I said, wait for it, because she was initially uncomfortable, and I could see her body language changing, and I can see her whole persona changing. So, to me, not only do I want the facts, but I also want the gestalt of the patient's experience. And to me, that's the greatest part of it, because then, you're beginning to develop an unusually gratifying relationship, because you're actually experiencing their experience a little bit. And you're actually doing what I think doctors should be doing, which is paying attention to patients and healing.
Well, and some of paying attention to a patient as they walk in can give you some clues to their joints.
Absolutely.
How they walk in.
How they shake your hand.
How they shake your hand. Are their hands dry? Are their hands
Carefully
cold?
they get in the chair.
Yeah. Do they, as you're talking with them, are they, can you tell if they are maybe have some dryness in their mouth and things like that? Now, that's difficult to detect, but you can ask a few questions on the backside of that probably increase your sensitivity of being able to find patients.
It's
with
those
some
little
of these
cues
conditions.
and being aware of them. When they come in with a cup of water that they got from the outside, it's, you'd think, oh, they're just thirsty, it's Arizona. But no, actually, do you have dry mouth? Do you have dryness? So,
That's so, it's a multi-system condition, Sjogren's, and many of the things that we've been talking about, the fatigue, the joint pain, all of those, as well as the more severe significant associations, occur. Do you find that looking at these patients from that perspective, if you think back to the patients you had, would help you? I mean, is there anything that we could think about developing a survey or?
I think that it's moved along the continuum at that point when they start to have joint pain and they
Maybe
have
too
that
far
dry
along.
mouth. Yeah, are they already advancing at that point as opposed to your patient that comes in and it's predominantly dry eye? I think those are the patients, and I certainly am guilty. I don't go all the way down that autoimmune path at that point. I'm stopping with, okay, here are the symptoms, here's what's going on, if they're more severe and they're further in the continuum, yeah, absolutely, I think that we could gain more, but I think that, what do you do with that patient that initially presents and they're, for lack of better words, the run-of-the-mill type of dry eye patient that is presenting and they kind of fit the demographics as perimenopausal, and I think addressing those and being able to identify those patients would really be helpful.
This is a little bit of a mindset shift here because,
Absolutely.
Traditionally we think of Sjogren's patients as the ones that ask the question about, eating the cracker. Do you have to have water? Do you have dry mouth? Do you have rheumatoid arthritis? How about your joints? You're right. Those are the ones that are probably, they're well on the road. They're rolling down that road already, and to determine who might roll down that road, I think, is where we want to
Yeah,
get.
find out who's more likely.
especially now, one of the things that I feel maybe more responsible for than ever in my career is that, we're a first point of contact for many of these patients. And unfortunately, medical care isn't what it used to be. A lot of these patients are not getting the time and the focus that they would typically get from their primary care providers. So if I am more aware of their immune status, their potential for rheumatoid disease, and I could be the first person and the first clinician to recognize this as part of something more significant and then direct them to proper care, I think that's a responsibility that optometry is going to bear more and more and more as time goes on, as we become more involved in first contact with these patients. So I think it's a natural evolution for us, and I think 2 or 3 years from now we'll be talking about the importance of that as optometry evolves with the new healthcare system. I'd
Right.
like to hope, anyway.
So Sjogren's syndrome is an autoimmune condition. Do you feel our colleagues have a good understanding of Sjogren's and its manifestations on the lacrimal gland and salivary glands?
I think as a profession as a whole and all eye care providers, there's a lack of understanding at what level, because what comes to everybody's mind is a much older female patient that has Sjogren's syndrome, and it had to start at some level. So I think there's a lack of understanding throughout eye care.
I think there, at some base level, there's a universal
Basic.
understanding that the condition exists. But to your point, I would agree that stopped at a certain point and never progressed beyond it, so they don't fully understand the associations and the ramifications. There are some things that we're very fortunate in eye care because we know, Behçet's disease, rosacea, and very often primary care physicians don't know very much about it, and we could make a diagnosis of non-eye things because we know the syndromes and the conditions. But I think you're dead on. I think everybody knows about it, but no one really knows about it.
Yeah, and I think we isolated it to such a small number of patients within practices, and maybe we who treat more advanced eye care see a greater percentage, but still, if you had to say, what was your percentage of Sjogren's patients, I'd have a very low percentage.
Because you're thinking of those
Well-
that are already identified and are very, very severe.
Yeah, and it may not be low. I mean,
Right.
it might be much broader, and it, most likely with the statistics, it is.
Yeah.
And if I just may add another point, we're all thinking that most ocular surface disease, most dry eye disease is evaporative, so we're thinking more evaporative than aqueous deficient, and which already limits us to a much smaller number, you know, less than 20%, and then it gets smaller and smaller. So I really think, you know, most eye doctors would say, yes, I know about Sjogren's, and yes, you know, it's a, you know, aqueous deficient disease, but there's only a few people, only a few. Those are the ones I would do Sherman's on.
And I bet you a lot of our colleagues say, well, I don't even treat those patients because they're so severe, I don't even want them in my practice, I
Right,
can't help them.
or somebody else is already treating them for
It's
me,
someone else's
yeah.
problem, yeah.
Well, I want to just touch one more time on something relative to the systemic effects, and then we're going to move into talking about dry eye and how we manage dry eye, just for a little bit. One of the notable associations was that there may be a genetic relationship, not necessarily a direct genetic inheritance pattern, but a genetic relationship with patients who have Sjogren's having relatives that have some autoimmune condition. Have you found that to be true, or have you noted that in the patients that you've seen in your practices, that there may be a patient who say, you know, I think I might have had, and they're not going to be able to describe it likely in the words of, oh, she had lupus, but that they'll describe a relative that had something that could be an autoimmune condition? Or maybe you don't ask it and think you should. You want to start?
I definitely should ask it more, but with that said, yeah, I can identify patients who have mentioned that they had relatives that had, and they were non-specific autoimmune type problems that they didn't, and some of them will even say they also, their mother also had a problem with their eyes, or a sister had some problems with that. But that certainly should be part of the history of really going laterally and vertically to find out whether or not there's other.
And perhaps that's in the identified dry eye patients, but this is a new way of thinking of Sjogren's, I think.
Absolutely.
And it's perhaps just another nugget or hint that could help push you along in understanding these patients better. Yeah.
You know, I definitely will go through the family eye history, but not so much, really,
Yeah.
the medical history. And honestly, the first time that I even did this for myself was a daughter's high school project, and we had to build a family health history tree. And, you know, as we went through this with my daughter and asked my mother and the different people that I knew, you know, all these little things that in my family I didn't even know about. So it's definitely something I haven't done for myself. So unfortunately, I'm culpable of not doing it for my patients either. I'll ask them about their eye history. But except for maybe diabetes, you know, only if I think that there's a concern in that particular case will I even go there. So it certainly would be something, and I'm not even sure that on the electronic records they ask for family medical health history, or do they?
Oh, don't get me started on electronic health
They may,
Let's quickly move into
yeah.
the diagnosis of dry eye. So I think all of you have specialty dry eye clinics, so you may be a bit different from what some of our practitioner colleagues have out there in terms of their own routine.
Before you shift,
Okay.
before you shift to just one thing, I wanted to actually get your guys' collective opinion. There was that statistic that we identified the other day, a comparison of, so in this whole dialogue about the prevalence, right? First of all, I can't tell you how awesome that was. It was really, really good. In the dialogue around the prevalence, this comparison of the perception of how prevalent rheumatoid arthritis is in the market,
Oh.
and yet there's 1.3 million patients with rheumatoid arthritis according to the Arthritis Foundation.
Right.
That's compared to the prevalence of Sjogren's, which is nearly 3 times as prevalent, yet no one would think that. Is that something?
Oh, that's, yeah,
there?
that when you asked that question the other day, I had said, you
Yeah,
know, just
okay,
guess.
yeah,
I mean,
right.
I was,
I was at 10 million.
yeah,
Yeah.
yeah.
It's a third how many patients actually have Sjogren's. I just was wondering if it would be okay.
Good
to-
for somebody to say that.
Yeah.
Yeah, why don't you say that?
I will do that. And the numbers again were, Jason, it was,
Why don't you
Wait,
say that?
According to,
So I know, and Ben had, there was another, I don't know, there was another resource he was at, but this is the Arthritis Foundation. It says an estimated 1.3 million people in the United States have RA.
and we don't know that it may be undiagnosed is more. All right, so we all know systemically that rheumatoid arthritis is a condition that our patients may have and may report to you. It's probably one of the more common arthritis type of conditions, and it has a awareness around it, you know, in the community. I think patients understand what that means and would know to report that. It's been found that 1.3 million patients have been probably carry the diagnosis of rheumatoid arthritis. So if you care to comment on the comparison between the number of patients with Sjogren's and rheumatoid arthritis.
When I learned that number of 1.3 million individuals with rheumatoid arthritis and compared to 4 million individuals with Sjogren's, to me that was a stunning statistic because you think of RA as being so much more prevalent, so much more awareness, and just out there an awful lot more, that there would actually be 3 times the number of patients that would have Sjogren's system. That's an alarming number to me.
It is. Well, it almost makes you believe that everyone with rheumatoid arthritis has a very, very high likelihood, if not already has, undetected or undiagnosed Sjogren's.
Be a very, very valid assumption.
Yeah. So you see a lot of really significant dry eye patients in your practice, severe. Just a gestalt of when you've asked them, how many of them have rheumatoid arthritis? Is it
Not an insignificant, well, first of all, my practice is, I think, complicated by environmental conditions.
Yes,
So
very true.
lots of people have dry eye simply because it's the nature of the beast. It's, but I would say probably 20%, maybe even a third. However, and I think it's important to recognize this, that number one, it may be the tip of the iceberg, particularly with Sjogren's, and number two, just because they have Sjogren's or rheumatoid arthritis doesn't mean that they necessarily have only aqueous deficient dry eye. They could have other issues as well, and I sort of alluded to that before. So I think one of the most important messages that we can get across to our colleagues is that dry eye is a complex, sometimes very challenging diagnostic entity, and we need to keep an open mind throughout the entire process. One of the, I think, greatest tools we'll have, and that's why I'm really excited about the ability for us to screen these patients, test these patients very, very early on for Sjogren's. I think we're going to discover that a lot of our patients who have meibomian gland disease, that have evaporative dry eye, that have dry eye for mixed, combination reasons, actually do have Sjogren's, and that's going to open up a lot of possibilities for us in terms of their management.
Kelly, when I think of my advanced patients that I'm talking to and asking about whether or not they have RA, I can think of so many patients that do exactly the same thing, and they go like this, and they go, sometimes I certainly think I do, but it's never been diagnosed. But they all do the same thing. They move their hand like this back and forth, say, sometimes I think I do.
Huh. That's a really interesting tip. New diagnostic
There we go.
test.
Yeah,
That would be
that's
the
right.
DeVries test.
Yeah,
Right.
right.
I like that. That's
I was
right.
just going to name it. You're not
That's
supposed to
right.
name it yourself. I like
That's
that,
right.
the DeVries test.
So we'll do the cracker test, we'll do the DeVries test.
There we go.
Well, then I'll ask you, Kathy, because I know that you love the meibomian glands.
I do.
And they are
And I
certainly-
love the eyelids.
And the eyelids, and that's a big part of your dry eye diagnostic workup. And certainly the patients with Sjogren's are very likely, actually, to have meibomian gland dysfunction. Talk a little bit about how dry eye workups occur in your practice.
Sort of a parallel track with wherever they're surgical, when a patient is referred to us, they're almost always on a surgical track, whether it's for glaucoma surgery or cataract surgery. So, I have the challenge of collecting data for cataract surgery, keratometry, and all these things that are, integral to successful surgical outcomes. And I'm challenged by an ocular surface that's not pristine or ideal. And, I'm doing two things at once, where patients will have to come back for remeasurements after I say, well, look, we do have to get better measurements because the surface of your eye is dry. Diagnostic tests including, tear film breakup time and staining, which all impact critical measurements in calculations and, critical care post, trabeculectomy surgery, that sort of thing. So I have to prepare the whole surface for the next process. So I'm not exactly sure that answers your question, but I'm traveling two tracks to get to one successful endpoint.
So in that, what type of diagnostic tests do you perform?
My favorites are checking for staining, because I think that certainly has you well along your dry eye if you're staining. But I think also very important is tear film meniscus height. And it's so important in every aspect of eye care, just that tear meniscus height, because even if you're trying to get tonometry, a thin tear film, once you do fluorescein, you'll get fluorescein quenching, and you can't get an accurate pressure. So that tear film height is very important to me, and I try to be very systematic about thinking about and looking at and measuring that. So it's really staining and tear film meniscus height, as well as, checking the meibomian glands, because that together, either by expression or just by looking at the surface of the eyelid margin.
What about you, Art?
Well, that's
Don't get
that's
you
actually
started.
that's actually very I found that very interesting because I consider you one of my heroines in terms of pushing the envelope with awareness of dry eye. And again, I'm very systematic. I look at the tear film and the ocular surface as intimately integrated, I guess. And the first thing I actually look at is just general slit lamp examination. Staining, I think, is critically important, both with fluorescein, and I prefer lissamine green to rose bengal because I like patients and I don't like making them scream. In fact, the Epstein test was the amount of pain is directly proportional to the dryness of the eye with rose bengal.
That's right.
So you can literally tell how we did a clinical a couple of years ago, and I could tell when we had a very dry eye patient in the office that my partner was seeing by the sound of the patient
Emanating from the room.
emanating
yes.
from the room.
Measured in decibels.
Yes, but one of the things that I think is critically important for our colleagues to recognize is the importance of tear film stability, because that's perhaps the prime directive of the tear film, to remain stable so that we have a stable platform for vision. And we have so many overlapping mechanisms to maintain stability that can go awry. So one of the things that I've become really enamored of is non-invasive breakup time, and we have technology. The Oculus instrument is a perfect example that allows us to utilize that. Also to measure tear meniscus height precisely and reasonably reproducibly, as well as meibomography. So that's really part of my dry eye workup, in addition to staining, and really just observation. I admit to not using Schirmer testing as as much
Well,
as
that was
perhaps
going to
I
be my
did.
next question, and I hadn't heard anybody mention Schirmer.
May I just interject for a moment on the heels of what you said, that even though we all do staining and we look at tear film count, what cannot be overlooked is the conjunctiva, because that is really the support system of everything else. And whether you have conjunctival chalasis that disrupts the flow of the tear film, you cannot stop at cornea.
Well, I've often heard, and I'll ask you about this, I'll have you comment on it as well. I've often heard that dry eye that is unresponsive to therapy is because of conjunctival chalasis. Now, what if those patients were those more likely to have Sjogren's, and we don't know that? And when we're attributing the non-responsiveness to that. Now, very well could be as well, but I do think that in light of of this here and what we're talking about, could be something to be further considered in the non-responsive patient.
And then you can ask a question: why do patients have conjunctival chalasis?
I don't think we know the answer.
Well,
to that.
and I can't think of a Sjogren's patient that doesn't have significant chalasis. I mean, they just seem to go hand in hand, but yet oculoplastics are very reluctant quite often to resect that conj and to jump into that arena, and I think it should be done at a much earlier stage, because you get those patients that are non-responsive, and you'd really like to find some reason, and it makes sense that the conj just looks so bad. There's so much staining, there's so much redundancy.
I'm sorry to interrupt. A couple of reasons, why they're still symptomatic, whether it be that the tear film is disrupted, or that the punctum is covered by redundant, conjunctiva, or the mucocutaneous, I can't get it out. Mucocutaneous junction is obliterated because of the way the conjunctiva is directing tears, and they can be very, very symptomatic.
You actually said something I think is really important that we touch on, and that is
I did.
actually everyone's sort of aimed in that same direction. The non-responsive patient is very different
Yes.
than the patient that you're working up initially.
And surprisingly, I think, and I'm going to intersect you, because I think that we treat them the same clinically.
Oh,
We look at them the same, whether they're responsive or non-responsive.
Absolutely. The basic workup is the same. However, you recognize that the pathology is probably significantly different. So I then begin to go further because, I'm thinking, I'm not the smartest person in the world, but I'm very tenacious. So if it's not a lack of tear production, if their meibomian glands aren't really that big an issue in the overall clinical picture, so what else? Is it partial blinking, something we never even thought about before, I think in the context of dry eye? Is it, Bell's phenomenon? I joked
Smile, yeah.
with one of my friends the other day. I said, in fact, it was with a patient. I said, I think the epicenter of absent Bell's phenomenon is California and New York, because that's where all the blepharoplasties are done. No one bothers to check Bell's before, and the patients come in with 1.5 millimeters of lid gap when they sleep, and this band of dense SPK, absolutely miserable because no one bothered to see that their eyes don't roll up when they go to sleep, and their corneas are exposed while they should be protected by the lids. So I begin to look for those other things a little bit more intensively. And I think that's where the expertise comes in. It's the non-responsive patient that's been to 5 doctors, and we can't just stop at the standard workup. We can't just stop at looking at the meibomian glands, meibomography, diagnostic expression, and those things. Critically important building blocks in the overall diagnosis, but there's a lot more to it. And looking for Sjogren's is maybe the most critical of all those pieces.
And let's talk real quick, though. I mean, do you do Schirmer in context of what you do?
I actually do. Schirmer's
Okay.
is part of my workup. I always reappoint patients to come back because they're going to be there for some time, and we're going to do. I just want to gather as much information as possible. I start out with osmolarity. I'll look at the tear meniscus. I'll do tear breakup time. I'll look for con staining, corneal staining, lissamine green staining on both as well, expressing the meibomian glands, measuring the lipid layer of the tear. And Schirmer's is the very last thing that I do, just because it is so invasive at that
Right.
point that you're not going to get much good information after that. And what I find in treating dry eye is these patients are so all over the place on the results of all of those
Okay,
tests.
yeah. In
Whether
addition
it's
to the
tear breakup
symptoms,
time,
yes,
to the symptoms, you look at that and you may have a patient horribly symptomatic, and the first thing you do is you look at the cornea and say, it doesn't look that bad. Or you look at the tear breakup time and say, I don't understand why this
Looks
patient's
normal.
like this. Is an 8-9 second tear breakup time. So I think gathering as much information as we possibly can, and still with that, there's not an absolute connectivity that A and B and C, and therefore that this is the underlying cause.
And I'm sorry, but I think part of the reason why that is because this is dynamic.
Yes.
It's not the same every day.
Yes,
It's
exactly.
not the same.
Well, and Sjogren's is dynamic too. They're going to
Right.
have cyclical periods where they're experiencing, significant pain and irritation, and then there have been many times when you have a Sjogren's patient that looks very normal, like their dry eye profile. They don't have dry eye that day, because they're measuring completely normal on most aspects. And there are Sjogren's patients that don't have overt dry eye.
Well, and
Or
initially,
manifest it.
early stages, that has to be absolutely accurate.
Yeah,
It just
that's right. That's
But,
right.
but Kathy, you just said something that I think it needs to be reinforced, dynamic. The body tries to adjust for deficiencies constantly, and you just happen to be measuring in a slice of time. You may be seeing something that looks really normal, and in reality, the patient is
And-
not normal at
I'm
all.
thinking you're a really good doctor.
Yeah.
But they just happen to be having a really good day.
We forget how dynamic it is. The eye is challenged by all kinds of intrinsic and extrinsic things, and our key to survival was our ability to adapt, and the tear film being dynamic in its response to all of those challenges. So dry eye patients actually respond as well. And,
Yeah, that's true. Especially in the mild to moderate stages, and that's
Absolutely.
where we're
Exactly.
aiming, try to aim some early
to catch them
detection.
early.
Now, in our clinic, we use the phenol red thread test first, so we'll do that, and then afterwards, even though you've taken some, actually we do the osmolarity first and then phenol red thread, because it only takes a few seconds and it's not as invasive as Schirmer to get an idea of their aqueous production. But I do agree that the tear prism is valuable, for many reasons, if there's stuff in it or how high is it and how does it look in terms of its quality. And those, I've always done that because I feel that if you're looking for Sjogren's, you need to have an accurate idea of the amount of aqueous that's produced. Now the guidelines for diagnosis have shifted somewhat away from the measurement of aqueous production and towards the assessment of staining. However, many rheumatologists, if they're referring patients into you, will still want to know what's the Schirmer.
Right.
So I think that we still have to have an awareness of that in the context of discussion with our colleagues, because it isn't universally adopted among rheumatologists or primary care providers that Schirmer isn't needed anymore. But it is something I think that we need to kind of keep as in our bag of tricks. In terms of overall evaluation of a Sjogren's patient.
What's your thinking on osmolarity in these patients? Is it from a diagnostic criteria?
I haven't had enough, I'd say, Sjogren's patients at the mild end, like where you try to do early detection, to know whether or not that is actually an indicator of anything down the road. But I do find even with my most severe dry eye patients, sometimes they'll measure relatively normal on osmolarity. It's a bit all over the map too, and I attribute that to not the test being inaccurate, but the eye being very variable and dynamic.
Reflex,
and things like that. I mean, I think taken together as part of the package of testing that we can do, you can get some valuable information there, and I don't think that you can isolate any one of these tests and make it be the one, the gold standard.
People ask me if you had one test to use, what
There's no
would you do? And I said, well, I wouldn't practice if I just had one test I could do.
That's right. And new technology continues to develop, and we didn't have the Oculus keratograph, and now we can look at my biography easily. So there's many, and we're going to find more and more and more over the next few years.
So I'm compelled to insert here once again that I do think that if you're staining, you're well on your way.
Yes.
So, when your rheumatologist says, do they have staining, that's really not getting to us early. That's really getting to us already
Late.
on the tail end.
It's very true.
I agree.
So,
I think if
yeah.
you have
I
patient
think
that
that's-
is in the early stages and you start treatment at that mild level, you're going to be much more successful
Successful.
in that disease. And that if you really wait until that patient stains, you've waited too long.
Right. And in fact, in some cases, we could talk about the treatment of the Sjogren's sufferer, but what we want to talk about is the treatment of the dry eye patient before,
The early Sjogren's.
the early Sjogren's, so that they're not a sufferer. Let's talk a little bit about the number of patients that have dry eye. So the other day, you saw this diagram, and I'm going to ask you, Doug, to talk about this momentarily, where it shows that there are approximately, this could be low, 12.5 million patients that might have dry eye. And from amongst that, the 4 million patients that have Sjogren's live. Tell me what your thoughts of this are in context to your management or detection of a Sjogren's patient.
Well, it tells me that if there's that number of undiagnosed, that I'm clearly not aggressively treating a significant percentage of my patients that are going to manifest, they're going to have Sjogren's, but are totally undiagnosed. And I think with that, what we're going to have is we're not going to get the same kind of compliance, the same type of understanding if a patient has that diagnosis of Sjogren's at that point. I found it a startling number. And I think that even the number of the 12.5 million may be low as well, on the low side. So, keeping with the same percentages, it could actually be higher. So I think that's a startling number.
Yeah, so the same number can be translated to 1 out of every 10 of your dry eye patients has Sjogren's.
It's unnerving, actually, because I think, certainly from my perspective, I really never considered that as a diagnostic option or a diagnostic possibility. And I actually feel that I've done patients a disservice by not being more open to that possibility. So I have looked at this area. I think the reason why we are so drawn to it and we're so fascinated is we're fixers. We like making a difference in people's lives. And for the first time, certainly in my career, our understanding of the ocular environment and the ocular surface and the tear film has expanded so greatly that we actually can make a significant difference. This is just part of that evolution, I think, and actually I'm very, very excited about it. And when I hear numbers like that, and I realize exactly what I've been unaware of and what I've been missing, it sort of motivates me to be
To
even
look harder,
more.
right.
Exactly.
Because I would have estimated, I mean, if that question was given to me, okay, what is that percentage of your dry patients that have Sjogren's? I would have been a tenth of that number. I mean, I would have been so far off on that estimate.
Exactly, and I would have been confident in that as
Yeah,
well.
yeah.
And that's why it's so unnerving, because
yeah.
it, like,
Well, and even for all three of you, who see more dry eye patients than the average practitioner because you've built your clinics that way, or you have a patient population that is it's that population, if you translate that to the number of patients you might have in your clinic, it's even higher than it's higher than others would experience. So, it's good to be on the lookout, isn't it?
I sort of feel bad when, whenever I'm assessing a dry eye patient. I'll ask them, so do you have any, is your mouth dry? Is it dry in your nose? And they'll say no, and I'm saying, okay, so no Sjogren's. Yeah, okay, let's move on. And I think anytime you're compelled to ask that question, you should be compelled to do the follow-up to that question.
that's a great point. And it reminds me of an interesting anecdote. One of my, it's a true story, one of my good friends is a physician in the Fort Worth area, and he went for a general physical. And he was sent for some obscure test just because the person conducting the physical was a friend. And they found something a little bit unusual, and they found lymphoma that was actually fairly nasty, but they found it well before it would have ever been found in a normal exam. It just was one of those things where they had some indication that something was wrong, and they followed that path until they were able to establish the diagnosis by biopsy. They were able to treat him, and it literally saved his life. Had that gone on for another 6 months to a year before it was easily diagnosed, he would be dead now. So it makes me realize that here we have patients that sit in our
Telling you.
chairs and
Telling
suffer
you.
miserably that we care so much about. Those are the patients that I want to go in the morning and see, but yet I feel so sad and drained because of their suffering. So if I could catch them well before the point where they get to that severe state where it's so hard to manage them, and I can actually intercede in their overall health by being the first person to direct them to proper care, and also address their eye issues at the same time, wouldn't that be great?
Yeah, it would be. Yep. Well, speaking of management, Doug, when you're managing patients that have known Sjogren's, let's just start there, and dry eye, what are some of the more advanced things that you might do to care for them, and how successful are they?
Well, I think that when a patient, and in my experience, when a patient really gets advanced, you get such baby step improvements, but they're so grateful. And I'll use autologous serum an awful lot. I will.
Can you explain that a little bit?
Yeah, autologous serum is simply taking a blood draw, spinning that down into a serum for 20 minutes, 4,000 RPMs. That serum is then sent to a compounding pharmacy and either mixed with a 1-to-1 or 2-to-1 ratio of balanced salt solution, and then put into tiny dispensing capsules that a patient will use over usually 8 weeks. They freeze the vials that they're not currently using, and putting the drops in every couple of hours to really give the building blocks, the proteins, the growth factors, the trans growth factors, a chance to heal that eye, because it just doesn't want to heal because it's so dry. And I do get results from that. I mean, it's very rare that I don't get some kind of a positive result, but it's not this panacea. It's not this cure. And again, the Sjogren's patients are thankful for any movement that they can get where they have, when they have very severe PEK that is unresolving, then I'll go to something like an amniotic membrane, either the dry underneath a contact lens or a ring on that. But I tend to get very, very aggressive. Patients are on an active cyclosporin from the first point that I see them, and then I really try to manage the environmental conditions with moisture chambers, doing what I can. Usually, those meibomian glands are destroyed at that point. There's very little meibum with those patients, but I tend to get very aggressive. I'll also use androgen ointment as well and compound that for patients. Omega-3 creams as well as omega-3s. So I tend to, my Sjogren's patients are on this laundry
Very
list.
extensive, yeah.
And you know what, and they're willing to do it. I mean, my most compliant patients are those patients because they're so uncomfortable and it's affected their life so dramatically.
Kathy, would you treat dry differently if you knew they had
Had
Sjogren's early?
I think intuitively, I'm speaking for everybody else, I think we all would. Because we sort of know what's coming down the line, and you're trying to slow down that train any way you can, because you know at the end it's going to be a train wreck. So, you know, I'm thinking if I can intercede, if we could work earlier, if we can stop that snowball, that cycle of inflammation, all these things. And this is what I tell patients, you know, we have to break the cycle, because it's just the big circle, that Rolando image. You know, once you get it snowballing, it's very hard to stop. You know,
And getting that patient to a rheumatologist earlier, because many of them on that early stage, you're seeing them, they're not seeing a rheumatologist at that point.
Right, right.
and you know, as therapies become, you know, developed and more, you know, and better, they'll get them sooner.
Ocular and
And
oral.
ocular
yeah.
and
So,
oral.
you know, in many instances, I've been surprised at how much the oral management of Sjogren's patients has improved their ocular health.
You know, that's an interesting point.
Very interesting.
You know, I was listening to Doug, and I realized that, you know, he's described so very nicely that end stage treatment when you reach for literally everything you have. A couple of things that you know that you didn't mention are scleral lenses, which is something that really does work very well for some patients, and bandage lenses. We've, you know, off-label use of the Dailies Total One has been actually surprising, actually stunningly surprising for some of these patients. So that's been very, very helpful. Focusing on meibomian gland function, again, I'm much more aware of that than I was before. I think preserving whatever you know, aqueous they have within their eyes is critically important. And interestingly, you know, I use very little Restasis for most patients, but that's one group that I use Restasis for fairly frequently. The orals are interesting because, and again, I had this conversation with Paul Karpecki the other day. In some states where ODs tend to be very oral limited, I think there's more co-management and more interaction. In other states where ODs can actually prescribe orals, I think there's probably a significant geographic diversity in their approach to the use of orals as a therapy for symptoms and issues with Sjogren's. Arizona is one of those sort of middle-of-the-road kinds of states. New York is one of those.
New York is a no state.
I know.
We can't do
Yeah.
anything in New York.
It's neither a red nor a blue state. It's, you know.
It's a no state. We can do nothing.
Well, you mentioned referral to a rheumatologist. I think that our colleagues would be familiar with that concept, and of course that poses challenges for patients if they need to go back to their primary care provider first and whatnot. But again, I think an earlier referral to rheumatology, but then having a two-way street where they're also sending us patients to evaluate on the other side is valuable as well. Can't also forget oral care, so I think they should be part of the triangle or triage with us in terms of care of the patient and making sure that all the aspects of a Sjogren's patient, you know, are taken care of.
Well, that's a great question, and I just wonder what the other panelists have to say. Do you co-manage directly with dentists? Because obviously they have a significant amount of oral issues, or do you actually filter it through a rheumatologist who then coordinates the care in general?
You know, I think that the dental loop is an interesting concept because I don't know myself that I've had sideways or horizontal interactions with dentists about, and that is a nice approach, actually. I mean, we all have a dentist, so why wouldn't we be talking to our own dentists about managing, having referrals within our own communities? It's a very easy connection to make, but one I think we've not quite done yet.
I would think it's great.
And I think most of the Sjogren's patients are, that we identify now, have already been identified, already have rheumatologists, and they're in that dental care loop, as opposed to if we're the first provider to identify Sjogren's, then yeah, we're sending to rheumatology, we're sending to dentists, we're really directing as part of that triad to get that care. But no, that's a great point. But I think we get that patient so far down the road now
Yeah.
that usually they're already within some of that care
I
system.
was actually just thinking out loud, because I was thinking that might be an excellent way of building a referral base.
Absolutely.
Absolutely,
Laterally.
yeah.
And I don't know, are there dentists who are like some of our colleagues who just wouldn't want those patients, and, because they're probably difficult to manage?
Well, I've certainly been to dentists that much like optometrists, have a very different practice mode. I mean, my dentist now will come in and do all kinds of looking and feeling and
Check your
and all
tongue,
checking
yeah.
these things to that didn't happen 5 years ago.
I get very nervous when dentists do feeling.
Well,
I
it's
don't
all
mind
head and
the
neck.
looking, but the feeling is.
But as we sit here and I think about the patients for the past month, I can think of 3 of them who were checking their watch because I wasn't quite done with them because they had to leave for their dentist appointment. So
But that's New York.
No, but that part A is New York. Part B is now we have to ask that question about, are you tired? Maybe should we ask, how much money do you spend at your dentist?
How are your teeth? How are your
How are your
gums?
teeth? How are your gums? Do you smoke? I think
Well,
that.
You showed a picture the other day, Kelly, that actually still frightens me. And,
Oh, the tooth picture?
The tooth picture. I'm thinking that, things that most people go, oh, that's disgusting. I go, no, it's not. It's like really interesting. It's just a big ulcer. And, I wonder if dentists would go, oh, that's disgusting. And then, the teeth thing we think is disgusting, and they find
Well, that's
perfectly
just-
okay.
I actually think that is probably true. I mean, they would be kind of grossed out if they saw a big ulcer, where we'd be like, what?
Yeah, just an ulcer. It's not
Right. Well, we've kind of been talking a lot about early detection, certainly, and in terms of screening, if somebody's going to go down the road of going to a rheumatologist, they're going to have serology performed. We know the traditional row and loss serology is not all that sensitive or specific at detecting patients early at all, but certainly at any stage where there's somewhere in the ballpark of 20 to 30% who will never test positive for either of those, even if they have diagnosed Sjogren's. So certainly a new panel, a blood panel to detect and provide earlier detection would be remarkable. You guys heard the information the other day when we discussed that there may be a few new markers that could aid in the diagnosis. I'll start with you, Art, if you want to make a comment about your impression of how that might impact the overall early detection concept in Sjogren's.
Well, it seems to increase sensitivity and specificity, which I think is a major step forward. That's number one. It seems to be far more accessible to us as clinicians, which I think is a massively important step. And I could see it easily becoming part of my armamentarium for patients that have moderate to severe dry eye, and maybe even some of the ones that have somewhat vexing, maybe even mild progressive dry eye. Again, the course of the dry eye might be one of the signals for me to actually intercede early. I particularly like being able to control it early on, and then being part of the major domo that conducts, what comes on, because I actually welcome that responsibility. So I'm actually very excited about it. It's a change in standards of care that centers around optometry, and I'm seeing this happen in a number of different areas, and I think it's refreshing, and I think it's very, very exciting.
So this panel would have, in addition to Row and Law, also known as SSA and SSB, it would have RF, rheumatoid factor, on it, as well as ANA. So 5 of the traditional components that are usually tested, but it would have these 3 new novel markers that would be able to detect with higher sensitivity and specificity early Sjogren's. It would require either taking blood, but using a finger prick to get a small amount of blood in office, or referring the patient to have serology done in a lab. How do you think that could be adopted into the optometric practice? I'll ask you, Kathy. In your setting, perhaps, how do you see that fitting into your dry eye flow?
I think that patients would welcome a test to help them understand what's, giving them trouble, the basis of their symptom. And it would be, I am extraordinarily excited that would be available, because often I would, even though I've thought about sending them for testing, I would say, well, it's not so accurate, and what's the purpose of coming back with no, and then we're left with another question mark again. So I think it would fit in very easily. I don't think there'd be any pushback from patients. I mean, well, they come to us, they have fluoresceins, they have all sorts of, mildly, they have injections, they have Avastin, this is just, a pinprick is certainly much easier than any of the things that we would do. And sending them for testing, for a blood test, I think patients welcome something to go to somewhere to find an answer. So whether I write the order for the test, or whether, we do it right there, any of the point-of-care testing is extraordinarily accepted by patients. They want to know the answer. They want to see the test. They're encouraged to know that they diagnose either one way or the other, and I think it would be wonderful.
Do you agree? Would it fit in your practice that way?
Oh, absolutely. My feeling is that point-of-care testing in general is going to be the standard of care within primary care optometry in the future. And having a test like this that you could intervene much earlier and look at that patient, and it wouldn't take much at this point, from what I know of the test, to pull that trigger to do that, from the standpoint that the patient has dry eye, and perhaps now asking them, is there any family history of any type of autoimmune problems, and going through a list with the patient. If they said yes, I think immediately they'd want to know, because that'll totally alter how aggressive I would get. You asked Kathy, would it change your treatment? Oh, absolutely. You'd get started much sooner, much more aggressive, and the patient would have an understanding. I rarely do serology on the Sjogren's patients now, because they're already there. I don't really care what the test shows, and I have a patient I think of all the time that she says, well, yeah, but I've never tested positive for Sjogren's, and I said, I don't care.
Yeah.
You are a Sjogren's patient the way your eyes are. And so I'm going to treat you accordingly. But even that patient, if she had a test, it would just change her mindset.
It may really alter compliance.
Oh, I think so. I agree.
Because they know that it's going to, we can tell them it's going to get bad for you. If we don't do this now, let's halt it now. So
Yeah,
I really
I
think that
completely agree.
compliance and early, more heavy management would occur with all of our colleagues.
Yeah.
Certainly. I have a patient who came into our dry eye center, so she wasn't my patient. One of my colleagues saw her. She had a diagnosis of Sjogren's, and so I had come back and I said, gosh, well, there's this new test that's going to be out. What do you think? I just kind of wanted her impression. This is how it would work. Then it would be sent off. Then you'd get the report in 48 hours. How would that have been, given that you just had to go through the process of getting the patient to the primary care provider, which was a big hassle, to be able to order the blood test and then get to another doctor and then finally find out, and all these steps, and the patient was frustrated by all of that, but she was pleased with the answer because it actually was positive. But she was fairly far along, so it was, too far along, I guess would be the answer there. But still in that scenario, and my colleague said, yes, that would have really... it would have cut out many of the middleman aspects of that patient-doctor relationship that were a hassle in that case.
Yeah. And the accessibility of the test in clinic, I think, is just the key to this ease of access.
Yeah.
Ease of access.
I also like the idea of being able to better communicate the course of disease with the patient, so that you can predict with greater certainty, not exact certainty, but with greater certainty, that they're going to be severely impacted by this, and engage them in their own process of managing it early on. And many of these patients become, as I mentioned before, very well educated in this. And I think that's great. I think it really is going to make a difference for these patients.
Really empower them.
Exactly.
Really.
Empower them. Well, certainly. I think something like this and all the other tips that we've discussed today will be a way to drop that 4.7 years down to something much more manageable. It'd be nice if it was, 1 year or less than 1 year, but even if it was 2 years, in my mind, that's a huge win, because that statistic was shocking to me. I just think 5 years of somebody's life in the healthiest time of their life is really something that you don't want to waste. And I feel like for many of these patients, they probably would say they feel like a good chunk of their years have been put aside to managing a very significant condition that they had no answer to.
And frustrating.
Yeah.
And-
So as we wrap up, could each of you just kind of, if you want to finish off on your patient or tell a final comment about your thoughts about Sjogren's syndrome and some clinical pearls, please do. I'll start with you, Art.
I think most of us got into the profession because we care about people. And I think some of us have been very fortunate to find ourselves or to create opportunities to be in environments where we deal with patients that have significant need. Sjogren's patients are pretty much defining of what I feel I've dedicated most of my life to. And they're among the most needy, that I could recognize them earlier, and I can initiate treatment quicker, and I could be part of a team that will help them more effectively, I think is one of the most exciting things. My patient right now is somewhere in Mexico enjoying a wedding of a family member. I believe relatively pain-free, because she has my own cell phone number and I've not heard. She also has my wife's cell phone number, who's also an OD. So, I wake up in the morning and see my voicemail isn't indicating anything, and I feel relieved. So I think my patient's going to do just fine.
I think, I am extraordinarily excited at being able to provide a diagnosis to patients who, with me, wallow in the frustration of why they have what they have, or why they're suffering what they suffer in. And I think to be able to put that closure on, whether the patient views it as bad, as good, just having them know, because, patients, why do I have this? Is this something I could do? But now, once we have a target, there are things that we can do, and that would be so gratifying to me. I think the patients with the driest eyes I have, again, was referred, and she sees her own doctor now. But I know she's not doing well.
Mm-hmm.
We did her cataract surgery, and her vision is better, but she still suffers, because we'll chat about her every now and again. But I would like to prevent other patients from her fate.
I'm very, very excited about this test, and I immediately think of the number of patients that I haven't had answers with. And it's that section of your dry eye that you're just saying, why won't they respond? Why don't I get the same? And not necessarily the severe ones, but the ones you're seeing progress. Mm-hmm. And I think, okay, those patients will immediately have this test run so that we can have answers, because that's what patients want, is they want answers. It explains, then also what's in front of them, and give them some expectations of what we really have to do to try and get some type of relief. But I'm very excited about the idea to be able to give patients answers, because they really do seek those underlying causes.
That's absolutely true. I really feel, and I want to thank all of you. You're clearly experts in this area of ocular surface disease, and certainly over the last 10 years, we've learned so much about dry eye, and from time to time we'll shift our focus into different areas of dry eye. Okay, now, wait, what about the meibomian glands? Oh, what? But I think we're getting such a global picture now of managing the dry eye patient, that all of these approaches help to either rule in or rule out key components that are part of the underlying etiology. It's not just this, here's a box of artificial tears, go home and I'll talk to you in a year, that it was 10 years ago. And I think that is such a huge service to our patients. So I hope this will just be the start of even adding just one more thing that's going to further improve our care of these patients, so that they don't get so, what did you call them in the beginning? They're not so distraught and upset, that we can prevent them from getting to that point and really improve the quality of life.
I
So,
think it'll make a
Improve the
big
quality
difference.
of life.
Absolutely.
yep. So thank you.
Thank
Thank you.
you.
Thank you.
Thank you.
I could have each of you just a close shot on camera say something like faux show or showtime.
Yo!
Show!
Years from now, when this is over, you can go back and say, hey, this is.
So we're going to have to pay you to not use this?
Showtime. Show. And that was
Serious. I knew you were
that's all
supposed
the
It's
rapper
time
you
for
could
the
Show
get.
me.
show, right?
Show me the diagnosis.
Yeah.
Show
did
me
I-
the diagnosis.
What did, no, I'm sorry.
It's showtime. It's showtime.
Hey, wait, what was it that you said? Show and what's
Tell.
your?
Oh, let's get the show on the road.
Not that, not that. Okay, let's get the
They,
show
they
on the
showed
road.
me. My doctor showed me.
My doctor
Show-
showed me. The one thing I'm glad no one said is, show me the money. So,
Show. That's his.
I said that to Mark right after the meeting.
Show. Actually, there's actually none of that in this.
actually, I really think that
like
this
my
was
doctor showed
really
me.
good.
Show.
I think we covered a lot of ground. And I think that's going to be very helpful from a clinical point of view.
Is there anything else you want?
No, I honestly, I can't think of a single thing that I would, that was.
No, that was one of the best dry eye panels I think I've ever heard.
That'd be good.
I thought it was really
These
good.
are awesome.
What, over the last, I don't know, however long it was, it seemed like it was quick, but whatever length of time it was what I would have envisioned this dialogue to be like 2 years from now. Like the fact that, I mean, just from where my experience was 6 months ago when this, was just a company that had 3 biomarkers to how much work it's going to be to try to figure this out. And I never in a million years would have expected that level of sophisticated dialogue
But not
about
just
this
that,
in such
you-
a short, I mean, that was.
But it's not a dialogue that we haven't it's already in our heads because we've been,
Right.
It's
we
right.
haven't been able to
Yes, but
verbalize
I've never heard
that
of
without
Lucy knows that
the.
it's in all of your heads, and we need to put it in
Into everyone's.
so many other optometrists.
But that's
who have
the
never
beauty
thought
of
about
this.
it.
The
As I-
structure that people
As I
were
keep pouring
approaching this
myself the
with is
water,
just phenomenal.
and my fingertips are
Differences, but
cold.
similar.
I know.
I'm ready to do that. I'm ready to do
Seriously, I
it.
need
Do
that
we
test.
have that?
I know we're all hypochondriacs, but maybe we do.
Yeah,
1 in
yeah.
10.
It's
Look,
funny,
I've been
my eyes are
drinking.
really starting to bother me. I
I
think I
feel
need
my
that test.
fingertips.
10 of us in the room.
Uh-oh.
Yeah, I know.
And
But we don't all have dry eyes. So if we were all dry eye and there were 10 of us in the room, one of us
No,
would.
no,
But we're
see-
not all dry
Who
eye.
has never had dry eye in the room?
Probably that guy over
Don't even
there.
talk about that.
It's pretty
Young, young one over there, that one.
It's pretty young.
No,
we
this
still
is
on
really
it.
good.
The
You can actually make this a
Roger
paid
asked me
for
if it was
service.
Show me.
Oh, that's so
It's making paid to listen to this. Are you kidding?
That's the nicest thing you said to me all
Actually,
day.
do a little videotape, put it in the diagnostic
not really
box that comes
darn
with your
close,
first starter
actually.
kit set, and then,
Oh, that's actually good.
What? Oh, a test in your.
No, actually,
like a little-
I got this for you. This was a great synopsis of expert care of the dry eye patient, some of the thinking that goes behind it, some of the advanced techniques. We had a really good smattering of that.
Just
and I
take the
think
snippets
a lot
of the
people are gonna get-
autologous serum. I'm like, man, that's
Yeah,
rolling
but you know
off.
what?
That's so
And-
good.
But you can also get albumin, so you don't even have to take
I was
your
you,
own,
you were like a Will's
right?
Eye manual.
You
I was
were.
like really
And
impressed.
then you spin it down 4,000 RPM and da-da-da.
I was like, yo,
That's
that's
right.
beautiful. Oh, can I
be looking for that.
Can I give you a pearl that a patient taught me?
Absolutely.
All right, you ready?
Yeah.
So a patient came in, and she sees the student, and then she sees me, and blink, and clearly she didn't blink the whole way. And usually the question that follows with that is, so because you don't want to ask, so does your boyfriend tell you sleep with your? So I said, so when you were in college, did you have a roommate? Did they ever notice that your eyes didn't close all the way? And it's funny how many times I'll tell you yes. It would freak them out. They would tell me. Sometimes they took pictures of me. So this one girl, I asked that question, and it was a negative. And then the exam continued on. She said, but you know what? My boyfriend told me that when we kiss, he wants to know why I don't close my eyes.
So she doesn't
What was
trust
he
you.
doing
That's
not
what she
closing
said.
his eyes?
She said, why? She says, why don't I close my eyes when I kiss?
You're a New Yorker. You know
And-
that.
and- and the
Say,
answer,
how do you know?
what?
That's it. Why you
What?
not closing his eyes?
What? Say it again?
She's like, there, I got
You know
my.
I don't close mine because he must not close his to be able to see.
Well, yeah, right. Because but her answer
of
was,
trust issues going on there, huh?
But my eyes are closed, and that. It's kind of, that's a sensitive question to ask, but that's how she knew. That's how she
So
believed.
you're
in me.
saying your recommendation is the Mastrada questionnaire is When you kiss your
right.
significant other, have you ever been told you don't close your eyes?
I mean, I will ask that. I mean, because and then she believed me. Then
Don't
she
bring it up with
believed me.
Shannon, whatever you do.
Right?
please.
Then she believed me. I just thought.
I actually, I had the.
Kiss somebody and they
folks
didn't?
from-
Yeah.
I was kissing some woman and she didn't close her eyes. I did not, I'm just kidding. I don't know what I was gonna say.
Some woman, I don't know.
No, but the lip of you, I actually did. I had them, they did the lip of you. on
You
me.
know,
And my-
gosh, I mean, almost all of my dry eye patients are like 1 out of 7 complete blanks on that test.
Yeah.
I mean, that's kind of false because you tell them to blink normally and they don't, but
Yeah,
they're probably
right.
more normal
They
than,
did, they saw it. I mean, you can see it in the replay. but
Yeah.
My eyes did not close.
yeah. I mean, it's pretty.
Your eyes didn't close either, huh?
So I think we should all just kiss one another and find out.
Ah. You know, unless this is vodka in here.
Is the tape rolling? That's
Yeah, all right.
the outtakes.
I had a patient that I treated for 2 years, and I kept trying to convince her that she had nocturnal lagophthalmus. And one day, she left the practice. I knew that was the last time she was going to be in the practice. She was upset. She went home. Next day, she called me, and she said, "I'd like to apologize to you." And I said, "Do tell. Why would you like to apologize to me?" And she says, "Because for 2 years, you've been telling me that I don't close my eyes."
They
And
don't believe you.
She said, "I went home. I was disgusted. My 2 grown daughters were over. I said, I've had it with that Dr. DeVries. He keeps telling me I don't sleep with my eyes completely closed." And they both look and they go,
Mom, you don't."
You can sit over in that chair and we always thought you were spying on us.
That's right.
And we found out you were actually asleep. So she said, "Okay, I want to make an appointment and now I want to do what you tell me to do."
Do you remember when I was taking pictures
So-
of
What
do you
people
do?
on the
What
F
do you
train
do?
with their
Well, the
eyes
first
open?
thing I do is do some
you
type of,
remember that?
kick up the lubricating ointment at
First
night,
of
but
all,
also I
taking
put on moisture
pictures of
chambers
people-
like
Yeah, where they can
tranquilizer.
keep their-
Dangerous.
Not correct the fact that the eyes don't
Yeah,
blink
yeah.
all the way, but these are things just to
Augment.
protect the
Well,
ocular surface.
Right.
At nighttime, they sometimes
come
they'll
to Queens,
or
huh?
mask, or if you can get them to
So
tape
funny,
their
New
eyelids,
York is
people get
so
really uncomfortable with that.
far away from
Women
it.
would never do it.
They want to.
Is there any relationship, and this may be a completely out of the wall question, any relationship with ptosis and eye blink and closure and
Of course there is.
there is, right? I mean,
Yeah,
it's because
there's-
it all has to do with the muscles, right? I'm assuming it's like the eyelid muscles, whether or not they're strong.
Well,
enough
there's
to do the-
floppy eyelid
Do you know
syndrome.
50% of your panel is from Reno, Nevada?
That's right, you know that, 50%?
Oh,
50% is from
50% of the
Reno?
panels from
Were you
Reno.
originally from Reno?
You're from Reno?
It's a Reno gal, yeah.
I didn't know that.
Biggest little city in the world. Show.
Oh, yeah. We did it. Oh,
You know what I love about Reno?
I didn't realize
When you
this
fly
was
in,
Yeah.
it looks like you're flying into the moon. It's like the
It's like you're going in the
well, the,
really
the
do your
geography
drop.
there is so different.
Oh,
it's
I
like
the drive from the Reno airport to, we were in Tahoe for our kickoff meeting last year. And it literally was like what I pictured, like the gold mine,
Oh, yeah,
gold
it
mining
does.
town
It
with
is.
the trucking going, right
Yeah, oh,
along
isn't
the
that
river.
just that is the
and the
most
old
beautiful
train
drive.
tracks that
I
are
love that drive. 80 up I-80.
I just trust
So
your
cool.
opinion.
That was the first time
you're
I've ever been
great.
up
I
there.
know. You know, I
Just don't forget that, 50% of your panel.
50% of your time is Reno, Nevada.
think you probably
Yeah, we're gonna have to
I think you
I do have
underestimate yourself. I think you're
to get on to something.
And that's one of the things. I
Great.
was talking about
Thank you.
that
It's fantastic.
and we talked about
That's
you.
fine.
I said,
You guys are
what I love
awesome.
about you is you have an open mind. You're
Okay,
always
let us
looking to
know
learn
if you need
things.
anything.
Yeah, well, for sure.
Always a pleasure.
Thanks for the.
Oh, thank you. Is that okay? Okay.
Really
Hi, you know, I
doubter about this. So this is really cool.
Understandable.
thank you, Kelly. That means a lot coming from both of you.
Better mousetrap than I love.
It's